Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I'd like to discuss a very important topic that unfortunately, or maybe fortunately, we don't see very often in the Pediatric Emergency Department. And despite our excellent training sometimes, those are some of the most challenging patients we have. I'm talking about when I see a child and I suspect he or she have a rheumatological condition. So rheumatological conditions are vast and very complicated and challenging. They have a lot of antibodies to check and a lot of things on physical exam to pay attention to. And that is exactly why I asked Dr. Robert Lowe to come on the show and discuss with us how to work up and how to identify the patients with the rheumatological or autoimmune condition. So welcome, Robert, to PEM Rules. I am super excited to have you. Just so you know, everybody, Robert and I have been planning this for over a year. Between him being almost the only pediatric rheumatologist in Las Vegas and me being busy, it took that long. So I'm super excited that you're here. Thank you very much, Robert, for your time.
It's a pleasure.
I'm going to introduce you briefly and you tell me if I got anything wrong.
Okay.
Robert, you are originally from Seattle, Washington, but moved a lot.
Yep.
In your life. I guess you used to live in Maryland.
Yep.
Next to the NIH. That was probably very inspiring.
It was.
And your dad was a physician there?
He was a cancer researcher.
Very nice.
At the cancer institute. He was a division head of toxicology at NCI for a number of years.
Wow. So you went to college in Philadelphia at the University of Pennsylvania, where you discovered you want to be a doctor or a scientist and you weren't sure. You ended up kind of doing both, went to medical school, got an MD PhD from the University of Washington. Right. And following this, you did your pediatric residency at Rainbow Babies and Children's Hospital in Cleveland, a hospital I know very well, and your fellowship at the same place. Is that right?
That's correct. The fellowship was actually a split between Cleveland Clinic and Rainbow Babies. And even though anybody that's from Cleveland knows that they're kind of arch enemies, they had to collaborate because they didn't have enough pediatric rheumatologists to qualify for two full-time pediatric rheumatologists in order to get accredited. So we spent part of our time at Cleveland Clinic and part of our time at Rainbow Babies and Children's Hospital, which was a pretty interesting stark contrast between Cleveland Clinic medicine and being at I would say more of a community hospital.
Interesting. And that seems to be the theme even today. I got to be honest with you. I've been a pediatric emergency doctor now for almost 10 years, and it seems that there are very, very, very few pediatric rheumatologists to consult with, which is why we're very excited to have you in Vegas. Super helpful. Robert, currently you serve as the founder and the medical director of the Juvenile Arthritis and Rheumatology Care and Research Center here in Las Vegas. You're also a clinical assistant professor at the UNLV School of Medicine, and you are one of the only two board-certified pediatric rheumatologists permanently in the state of Nevada. And correct me if I'm wrong, for the longest time, you were the only one. Is that right?
That's correct. After COVID hit and the helpful pediatric rheumatologists that were coming up from Children's of LA for a few days every month, they weren't allowed to come to Las Vegas because of the concern about quarantining for a couple of weeks coming from a hotspot like Las Vegas. So I inherited about 1,000 kids over a period of a few weeks.
So we certainly need subspecialists like you in the city. Super excited to have you today. And if you know the show, you know the first question, and I'm very curious to know your point of view. What is your definition of a good pediatric ER provider? One who does what?
I think one who listens and continues to think about what might be going on and doesn't make a snap decision. I know pediatric rheumatology is about as far as from pediatric emergency medicine as you can get in terms of the amount of time that you have to spend with patients and the acuity level of the sort of things that you need to address. But I think one thing we have in common is being a careful listener and not jumping to a diagnosis too quickly, because that's when I've been called for consults from ERs. It seems like the more experienced pediatric emergency medicine doctors aren't distracted by maybe a positive antibody test in the patient's past, or a grandparent who has rheumatoid arthritis or something like that. They really take in everything. And because the diagnosis is really almost always in the history when you take it, and I know that time is so precious in the ER. That's not easy to do, to sort out what are the critical issues, but not jumping to it too quickly is what I see in really the best emergency medicine doctors that I've worked with.
Very nice, and thank you for saying that. The pediatric emergency department, in most places where I've worked, is always busy. So certainly there's less time, but I certainly appreciate what you said. It's actually one of my PEM rules on the podcast. To be a good physician, you got to get a good story.
Yep.
I never discourage any of my residents and fellows to do a good physical exam, God forbid, but it's really almost always all in the HPI.
Yep.
So I certainly agree with that.
I couldn't agree.
And Robert, this doesn't happen very often. By far, pediatric conditions or rheumatological conditions, rather, I don't see that very much. Even in Pittsburgh, like a very big academic center, by all means, most of my patients have infectious diseases or trauma and otitis media, strep throat. Even oncological conditions are unfortunately more common, and the kids with rheumatological diseases are far and few in between. So it really doesn't happen very often that I suspect a patient of mine has a rheumatological disease. But let's say I do see someone, and this happened just a few weeks ago, when I see a child, previously healthy, and I have the concern for a rheumatological disorder. He has joint pain, maybe swelling, maybe tenderness to palpation, maybe even some more red flags like weight loss. My question to you is, what details would you need us to get in the H&P and the physical exam and the workup before we call you or before we send this patient to outpatient evaluation by you that will be most helpful?
So I think that's an excellent question, and this is I always appreciate because it seems like most of the pediatric ER doctors that I work with here in Las Vegas actually get this right, and so I want to applaud them because, like I said, it's not easy. But certainly, since there's two kind of broad categories of kids that have rheumatologic problems, about half of our ongoing patients have juvenile arthritis. And that is actually diagnosed because not based on any lab tests, certainly not an ANA test, and I'll go more into that later. But based on whether or not they have one or more joints that have been swollen continuously for 6 weeks or longer, that's not due directly to an injury or an infection, particularly in the joint. And it's as straightforward as that. And it can be hard because kids can come in looking pretty crummy and even refusing to walk. But I can tell you that most of the time I get called in situations like that. These are kids, they may actually have swelling and they don't look good. And they may or may not have a recent illness, but most of them have what we call reactive arthritis. And all that means is that they've had some sort of infection in the last few weeks, and their immune system has kind of rebounded. And while the infection wasn't in the joints, before their immune system gets things sorted out and calms down the inflammation after fighting the infection, it tends to irritate the joints. And the difference between a reactive arthritis and a diagnosis of JIA is that in reactive arthritis, the immune system does what it's supposed to do. It calms down the immune system, and within 6 weeks, the kid's better. And one thing that I think is particularly helpful in a situation like that is one characteristic of kids with reactive arthritis is that one, that there isn't any history for months and months of joint swelling. There might be of joint pain because kids get joint pain for all sorts of normal reasons that have nothing to do with autoimmune disease, like hypermobility or flat feet. But actually, they're remarkably responsive to NSAIDs, and most of the time, and this is true more often than with a lot of the other things that are in the textbooks for rheumatology, is you give these kids appropriate dosing of an NSAID. Toradol is probably overkill for these kids, but certainly naproxen. You get them on it just scheduled, and then overnight and in the morning they're jumping around, and the nurses are wondering why they were admitted because they look so much better. So that's not always true, but I'm continue to be surprised at how often that is true. That a kid who absolutely refusing to walk, ortho's been called. There was consideration of trying to aspirate a joint. And, if they say, no, it doesn't look quite that bad, let's just watch them overnight. And then by morning, if they've been on an appropriate dosing of NSAIDs, it responds incredibly well. Whereas juvenile arthritis generally doesn't have an acute presentation like that. And because the swelling in juvenile arthritis, the pain comes from excessive swelling, and it's something that develops over, often weeks or months, not overnight. And that's one of the things about trying to identify kids with joint pain and determining, is this a kid that might have juvenile arthritis? Then there's the entire other group of pretty much all the others, like lupus and mostly the systemic autoimmune conditions. And for those things, what we're looking for is inappropriate, persistent immune activation. And even though the ESR is notoriously nonspecific, it is very good at sort of integrating a whole bunch of factors. And so if a kid has been having has an ESR of 22, which is a little bit elevated, but they also have a C-reactive protein that's a little bit elevated, I don't get too excited about it because that ESR is elevated in proportion to what you would expect from a CRP or an infection. Okay. What really gets my attention is if there's a high ESR, like let's say 60 or 90 or 100, and the CRP is normal or almost normal. That is very concerning to me. Now, there is a window in which we do seem to catch these kids where they are getting over an acute infection, and the C-reactive protein will normalize faster than the ESR. But generally, the ESR won't get up that high if it's an acute infection. So a high ESR with a normal or near normal CRP is a big red flag. And in those cases, what I usually will recommend is to get our basic labs, so a CBC with diff, a CMP, in particular a CMP, not a BMP, because I do want to know if the liver enzymes are okay. And then the ESR and the CRP those are the main inflammatory markers that I look at, and I really can't interpret an ESR without a CRP, because if I only have a high ESR and there might have been some infection, it could have just been an infection. So that would be one thing I would strongly recommend. Don't get an ESR without a CRP if you think that you might be calling a rheumatologist, because we're going to really appreciate that information. And then there's the secondary inflammatory markers that tend to be more frequently elevated in rheumatologic conditions than in regular infections. And that would be the D dimer, which we're not looking for kids that necessarily have a clot that we're thinking about, but there are, when the immune system is chronically activated, they do tend to be in kind of low grade DIC. So where you can get a D dimer of 1.5 or even 8.5 when there isn't a clot. But what's happening is with the immune activation, they are making small clots and breaking them down rapidly, which results in an elevated D dimer in the absence of a clot. Now, certainly if a kid has the typical symptoms of a clot, like chest pain, and we're worried about a pulmonary embolism, or a DVT, that's separate, but usually when I'm asking for a D dimer, I'm looking for evidence of an unusually activated, chronically activated immune system that is not getting itself under control. The other ones are ferritin. Again, I'm not necessarily looking for whether or not the child has an iron deficiency anemia. Ferritin is very, very sensitive. So that is kind of like an ESR in terms of the fact that it can be appropriately elevated. Might be, over 100 in a kid that's very sick. But if you see a ferritin that's in the hundreds or heaven forbid in the thousands, you're dealing with a whole different animal that's almost definitely going to be rheumatologic, and it could be something very serious. One of the things that scares us the most is something called macrophage activation syndrome. And this is kind of like a cytokine storm, similar to what people think of with COVID. It's a little bit different, it turns out, in the details, but the bottom line is the whole immune system is so activated that you could get a bone marrow and their macrophages are consuming cells within their bone marrow. Now, obviously, we don't do that for everybody, but that is the scary thing about macrophage activation syndrome is that but by the time kids can be diagnosed by reach criteria, there's a 50% mortality rate. So if you ever see a screaming high ferritin, call me. I don't care for any reason, because unlike what a lot of people think of HLH as in a condition, but macrophage activation syndrome is kind of like a secondary HLH, where it's not you've inherited the genes that cause hemophagocytic lymphohistiocytosis type reaction, but it can be caused by anything. It can be caused by systemic juvenile arthritis. It can be caused by lupus. It can be even caused by a severe infection. And these kids, when their immune systems are pushed this far, they will uncouple, and they can progressively go into liver failure, kidney failure, respiratory failure. Now, it's not overnight, and so it's not something that you need to worry about like that. But I've met a number of senior pediatric rheumatologists that would argue that every child that comes in to the hospital with a fever should get a ferritin. It's cheap, it's quick, and if it's only mildly elevated, then you've essentially ruled out the uncommon kid that might be there with early macrophage activation syndrome, in which case identifying and treating it aggressively and quickly could mean the child's life. But those kids look really sick. So they're not going to be a kid that comes in with sniffles that's going to have a high one. But this whole idea of culture negative sepsis in rheumatology, we think a lot of that is probably most likely macrophage activation syndrome or some form of it, where there isn't an infection, but it looks like it because the whole immune system is just starting to consume the rest of the body. And but in any case, so those inflammatory markers. One other thing too is I always appreciate with a urinalysis just to double check there's no protein in the urine, is to always get a random urine protein to creatinine ratio. Because what do you do with a protein of 1+ or 2+? Is that a problem? Well, if it's concentrated urine, it may not be. But if it's not concentrated, and you can sort of look at the specific gravity and say, well, it's concentrated or it's not, the easiest thing to do is to use a roughly constant urine creatinine to normalize the amount of protein in there that will be concentrated if the urine is concentrated. So right there, I can say, okay, I don't have to worry about proteinuria if this is under 0.20 or if it's close. So, and there are some exceptions to that, interpreting that. Little kids can sometimes have a slightly high urine protein to creatinine ratio because they have so little muscle, they don't have much creatinine. So that ratio actually looks a little bit higher in a dangerous area, in which case I just look at the total urine protein. And if it's awfully low, then there's less concern. But those are the sorts of things that are very, very helpful for me. Now, if we have a kid who, is in the right demographics, maybe a teenager or something, they do have a history of just like seeming like they've been sick for weeks and weeks and weeks. They've been to their pediatrician, they've been to the ER, and they're just not getting better. Then things like lupus and lupus-like conditions are definitely much more on the front burner in terms of excluding, depending on the age. Now, 5-year-olds don't get lupus, but they can get mixed connective tissue disease, which is a cousin of lupus. Sjogren's can show up in a lot of different ways. So the autoimmune panel, if it looks like one of these kids might have this, I would not get the ANA test, which everyone kind of is gasping at, because that's the first test on these autoimmune panels. And that's why I recommend not checking that box of autoimmune profile, because it is going to give you a lot more misinformation that's going to scare parents. One of the worst things that can happen and it's usually not from the ERs, thankfully. It's from the primary care doctors. They order this autoimmune profile when they're like, well, this kid just keeps complaining of this, and I don't know, I can't tell what's going on. There was a grandparent with rheumatoid arthritis. I'll check this autoimmune panel box. And the problem is the very first test on it is this horrible test called the ANA, it stands for anti-nuclear antibody. And the problem is it's a 50 or 60-year-old test that is dated and is no longer useful, but is very good at causing emotional distress, because the problem is it's positive in 20 to 30% of healthy kids. So if you look at how many of those kids really have lupus compared to how many are positive, you're looking at like 98% that are positive, that it's a false positive in terms of predicting lupus. It is not a lupus test at all. And lupus is not something that you're ever going to diagnose just based on an ANA. It's going to be on the whole clinical picture, the history, the symptoms, So this is the whole idea about pretest probability. I mean, if a kid doesn't look like there's any chance that they have lupus, and by the way, lupus in kids is typically severe, at least when they come to medical attention. In adults, it can be very mild. And so a lot of people might know adults that say they have lupus, they look perfectly fine. They take their hydroxychloroquine every day and they're fine. That's not usually the case in kids. The kids with lupus often look quite sick, or they're going to be sick in a matter, very, very sick in a matter of weeks. So you don't do an ANA test to an otherwise healthy looking kid. I don't care what the family history is. The genetics actually don't play a very big role in most autoimmune diseases. There's a few notable exceptions like ankylosing spondylitis, which most people probably haven't heard of. But psoriasis is genetically strong, but that's pretty obvious. And that doesn't usually put people at risk for really severe systemic autoimmune diseases, just psoriatic arthritis. And these periodic fever syndromes, which are strongly genetic. But the problem with that is that kids get sick frequently. They get a lot of colds. And in fact, it drives these parents crazy, because they do have ER doctors and their primary care doctors telling them something that's 99% correct. And that's, hey, kids can get infections every month, especially the first year or two that they're either in daycare or in kindergarten or things like that. So the things for the periodic fever syndrome kids that are remarkable is how high their fevers are. Often it's 104, 105. Things that really cause people to gasp and wonder, does this child have meningitis or something really awful? And what's remarkable is how few symptoms they have. They don't look like they want to do anything. They kind of lay down and they don't want to eat. They usually don't end up in ERs because they will hydrate. They will drink fluids. So they don't often end up in ERs. If they're in the ERs, it's because it's the first few times it's happened to the family and they've been told your child has a high fever, you got to take them to the ER. The parents will stop taking them to the ER. In fact, even to the extent that people think they're being reckless, but they say, I know they've got a fever 105, but it's going to last for a few days. I'm just going to keep them comfortable. They're hydrated, but it doesn't matter if they get an antibiotic or not. I mean, we still need to take kids in, to get their throat swabbed because of the risk for strep throat. and the consequent risk of rheumatic fever if it's not treated, because most kids will get over strep throat on their own without antibiotics. But that's how we've developed this kind of unique pattern of having kids swabbed, and 90% of sore throats are going to be viral, not strep, but it's because of that legacy of rheumatic fever, which we still very rarely get, but fortunately it's rare, and it's because we're all taught to take our kids in to get swabbed if they have a sore throat for a few days and they have a fever, maybe stomach ache. But in any case, I kind of diverged away from the helpful things that I should be telling the ER doctor, because it's busy and they don't have all night for me to tell them about all the interesting things to look for in a patient with rheumatologic conditions. But so the specific antibodies in kids that where this has been going on, and like I said, the red flag here is repeated visits to the ER without an answer, repeated visits to the primary care doctor. And because these things can wax and wane. So I wouldn't get the whole panel. I would avoid the ANA test, but the specific antibody, and the reason why the ANA is so terrible is because it's positive if any one of 150 antibodies are positive. And for kids, there's about 5 out of those 150 that are actually helpful, but it's only helpful if they're strongly positive. So a borderline positive is not very helpful. And you really only know what's strongly positive if you look at thousands of these like I do. So it's okay to refer for a positive one of these. So the double-strand DNA antibody test, most people are aware of, and the Smith antibody test, or SM. This is something that is very important not to order a smooth muscle antibody test, because I've had actually twice in the last month, when I've asked for Smith antibodies, someone, the smooth muscle is SM, and that gets ordered, and that actually had false positive. And I had parents that were looking it up and thought their child was going to die of autoimmune liver disease when they were perfectly fine. Their liver was fine. The liver enzymes were fine. They didn't have any problems. So if you're going to order the Smith antibody, which is helpful if it's strongly positive for diagnosing lupus in kids, make sure it's Smith and not smooth muscle antibody. That's really, really important. One of the other important antibodies is the RNP antibody, ribonucleoprotein antibody. And that is one that is often high in kids with mixed connective tissue disease, which is a cousin of lupus that is more heavily involving joints like arthritis and myositis. So those kids can come in looking pretty crummy, swollen joints, pretty achy. But the problem is the RNP antibody is frequently borderline positive, and which we can usually ignore if they don't have all these other symptoms. And something that's been even more problematic is having had a COVID infection can cause you to have a weekly positive RNP antibody. And there's actually they've actually lined up. There's some molecular mimicry here, which is disturbing. And then so besides the double-stranded DNA antibody, the Smith antibody, the RNP antibody, the 2 Sjogren's antibodies, the SSA antibody and the SSB antibody. So those are the 5 that are really helpful. There's a whole lot of other ones. There's anti-chromatin, there's anti-SL70, there's lots of other ones. The problem is that those generally are not helpful for kids. And if they're positive, they're usually a false positive. And again, parents will worry about this because then they get referred to me for follow-up. But I have a 3-month waiting list. So for 3 months, they don't sleep at night. So that's why that's why getting an ANA test is not a good, and particularly for the Las Vegas area, I'm on call 24 hours a day, 7 days a week, and any physician anywhere can call me anytime, day or night, and I would be very happy to talk to them about if they've got a kiddo that they're concerned about and they want to make sure that they order the most helpful antibody tests and make sure that they get follow-up with me in a timely manner if they sound sick, but not sick enough to be admitted.
Robert, the more you speak, the happier I am that I brought you on the show, because I would say at least 50 to 75 of what you said, I honestly did not know. I think this was extremely helpful, what to do, what not to do. Right. And you really answered most of what I wanted to ask you. I'm going to ask you one more question. Thinking like a pediatric emergency doctor, I think of things simplistically. I always learned in pediatrics, in general pediatrics and pediatric emergency medicine, that weight loss is a very, very big red flag. My
Yes.
question to you, how sensitive is weight loss in rheumatological conditions? In other words, if I see this child, somewhat concerning history and maybe even physical exam for rheumatological condition, but there's no weight loss and he or she look very well nourished, how
Right.
reassured should I be?
Um, not always that reassured. I like you, when I hear about a lot of weight loss, like most people, the first thing we worry about is there a malignancy here that's been missed that has to be identified and diagnosed and treated without delay. But we do have that with kids with systemic JIA or lupus, that they'll lose weight, or dermatomyositis. They lose weight and they can look weak or in a lot of pain. But the problem is they can be early in the process. So often it only happens after it's been going on for a few months. And ideally, it becomes more obvious. We say these kids declare themselves when they lose weight, on top of all, their unexplained fevers or rashes and our other symptoms. But I would say that the most reassuring thing about that hasn't been weight loss is that they it's not as likely that they have some horrible malignancy that hasn't been picked up yet, and it also means that they probably don't have like inflammatory bowel disease, lupus, or one of these other things that have been going on for months and months, because it does usually cause a couple of months before they start to have a noticeable weight loss. So it's tough, but I wouldn't say that you can say that they don't have a systemic autoimmune condition, because for instance, the kids with periodic fever syndromes, which just drive parents crazy. These are the ones where the kids are told that it's a virus, it's a virus, it's a virus, and you know what? 99% of the time, that's correct. But those kids aren't going to lose weight. Most Sjogren's patients, for whatever reason, don't lose weight. So it really has a lot to do with the chronicity, how long it's been going on for, whether it's months and months, and whether or not it's getting more severe. So yeah, so weight loss can happen, but it always gets my attention. And sometimes my next thought is, how can I get this kid bone marrowed so that I can diagnose them with something I'm taking care of and treat them. In fact, that just happened a few days ago, that I had a kiddo that had a 20-pound weight loss, and over the last year, which was kind of strange. You'd think that if he had cancer, he would have declared himself by then. But before I could start using steroids, because you can't use steroids in a kid that hasn't had a bone marrow biopsy yet, because you'll mess up the biopsy in terms of properly diagnosing, classifying their malignancy. I can't touch them with steroids, which is one of the first medicines I use in an acutely ill kid with an autoimmune condition, until the leukemia or lymphoma has been ruled out.
Sure.
I would say the weight loss is absolutely concerning, particularly if it doesn't look like a malignancy. I would say, yeah, it's probably very, very, very concerning for an autoimmune condition. We just don't have very many kids that are chronically infected, like with tuberculosis and things like that. So fortunately, we don't see something like that often. So, but yeah, weight loss is always concerning, even to us, because it means something serious, whether it's rheumatologic or not.
Yeah, I always, I try to keep in mind to always ask about it and teach my residents and the fellows to do the same. Robert, again, I cannot thank you enough for coming on the show. This was extremely helpful, not only because you're so knowledgeable, because this is not something we see very often. And even after good training in Pittsburgh, this is something that I think all PEM physicians can get more and more information about. So thank you very, very much for coming on the show. I know you know the drill.
Yep.
You get to choose the outro of your choice, and I guess you wanted to hear More Than a Feeling by Boston. Is that right?
Yep, absolutely.
I'm guessing you were a teenager in the 80s. Is that right?
I was.
There you go. That's like my wife. You like the same music.
Absolutely.
Um, I already found a tutorial online how to play it. It will be a pleasure to do. Thank you so much for coming on the show, and thank you so much for all the work you do for so many years in kids in Las Vegas. Thank you so much.
Thank you. And I would like to say a shout out. Give me a call, okay? I give out my personal phone number to all physicians. I'm here to educate and help take care of these kids. And you don't have to have a great reason. I love to teach, if you're an ER doctor, don't hesitate to call me anytime, day or night. I always relish it, and I love working with my emergency medicine colleagues.
Thank you so much. Thank you so much for saying that. And again, thank you so much for your time.
Thank you.
And that is it for today, guys. Thank you very much, Robert, for coming on the show, and thank you for your excellent teaching on a very challenging topic. I hope all of us have learned from Robert's wisdom. Please check out the show notes with the summary of Robert's recommendations for labs you should obtain when you suspect rheumatological disease. Those can be very helpful. And again, thank you for supporting Pain Rules, and thank you for listening. Don't forget, I do have a Facebook page now with some educational material, so please check it out and share with your trainees. And as usual, feel free to check out painrules.com and contact me with any information you need, or maybe if you want to come on the show or you want to be a guest and talk about anything PEM related. As always, thank you very much for your support. This is my attempt to try a song from the 80s, More Than a Feeling. Robert, hopefully I deliver. And thanks again for coming on the show, and thank you all for listening. Have a great day.